have this discussion with your TRT provider prior to starting TRT to make sure they even have a protocol in place.
Make sure your practitioner has those protocols in place. A lot of people don't even realize it. This patient has been on TRT in your clinic for 2 years. And patient's 29-year-old male who, since that time, got engaged, got married, and now is immediately desirous of fertility, or at least within the next year. His wife, his brand new wife, and he are going to try to have it conceive. How do you approach it?
What I would do specifically, and what I do for my injectable patients, is I drop their dose by half of their testosterone, and I add in Clomid, and I want to see TRT levels maintain.
Hey guys, welcome back to another episode of the Vitality Code podcast, powered by Vitality Telehealth for all your telehealth medicine needs. I'm Dr. Jason Farrah, along with my wonderfully bearded co-host, Dr. Jeffrey Farrah.
It's looking good today.
Is the oil content good?
I never did hear from Grave Before Shave. What the heck? Are we not getting the global reach with our podcast that we?
and we're still waiting to hear from Goat Fuel too.
Oh God, they can have their goat fuel. Actually,
what happened?
No, I just got off it for a minute because I was sucking them back. I was doing goat fuels and bacon before my marathon.
Jeez, good God. That's also, please, folks, there's no medical advice here. This is not, jeez. My gosh. You know what? The longer I go in this space or as a medical practitioner or just a human in the last decade, the more I'm against energy drinks, although they're awesome. They taste so good. I love it.
Don't tell Grady. He's already got we've been railing against them. And so I limit myself. I do every other day in the clinic. My new nurse, shout out, she keeps me honest. She's like, are you drinking your water? Are you drinking your water? I'm like, geez, leave me alone. I got a monster today. But so it's every other day. I can't have one every day.
That's good. It's good to put that limit on it. It's just for it to. I know, but man, they and they know that, right? I mean, they obviously they want to sell their product, but they're just so bad for you. I see so many people in the clinic with high blood pressure and tachycardia after. It's just awful.
Yeah,
we're not here to talk about that though. Recently on the podcast, we have been making a foray into the world of fertility in the TRT patient, specifically men's fertility so that, you know, a whole other episode and a whole other probably specialty and personnel that's way better than us to describe it in the female patient. But in the general, as two physicians who practice bioidentical hormone replacement therapy as well as TRT in their clinics, we do run into this, and it is something that we have to confront and help our patients at least understand all the time, and deal with, and maybe even on a basic initial level, at least do some treating. Are you treating people currently in at least a initial rudimentary way to get started?
Why are you calling it rudimentary?
You know, this is the second time I've been dogging on you.
I know. My testosterone was like 110 or something.
And you're awkward, bumbling. Jesus.
You were
That's
half
the
a
connotation,
man before
right?
you started testosterone. I didn't even have a beard.
Yeah, now look at you. Look what testosterone can do for you. You too can have the beard of a grizzled outdoorsman.
God, I can't wait. One of my patients the other day said, yeah, when I retire, I'm going to be borderline homeless looking. I was like, yes, I can't wait to just let it all go. The beard
There's
is
nobody to impress, nothing to do, going to work.
Can't wait. So good.
What about basic human hygiene, though? You'll continue that, right? I mean, you're not going to.
I do. I am a fan of hygiene. I actually do more now that I have a beard. I have a whole routine. It's funny because I have claim, and it's a standing joke in my house that I've been mistaken for a homeless person before.
Oh, I could. Well, that was before the beard. I could.
No, I was with the beard. It was in Alabama.
That's your general
actually.
Gestalt.
Me and Nyla. It was the best.
Oh, Nyla?
Lady.
She was giving you guys
she did.
money
she
or
gave
something?
us clothes.
Oh my gosh.
Sweet Alabama
Jeez.
Southern Baptist. Oh, bless her little heart. Oh,
Bless her
funny.
little heart. Little pea picking heart. What were you? What, pray tell, were you wearing?
I think it was less me. I'm hoping it was more. I'm gonna throw my daughter under the bus. It was more my daughter. Probably a combination. So she refuses to wear shoes still to this day. She's 12. I don't think she barely wears shoes. So we were in Alabama, northern Alabama.
See, I think that's over. Hold on a second. I get it in a way, but that's over. What's the word? That's dangerous / over. I don't know. It's not as fun as it sounds. I've tried it, and I'm always like stepping on things that hurt my feet.
Well, it's because you didn't start when you were a baby. This girl's never worn shoes. Man, she walks across the parking lot.
On the bottom of her shoe.
It doesn't. Yeah. I mean, it's a blacktop parking lot on the way to Publix, and I'm like, it's 110 out here, and her feet doesn't care. Every
like
day,
those,
all
like
day.
the mountain people. There's like
100%.
Is it Machu Picchu or Peru or somewhere in South America where they'll run barefoot through the mountains, and I'm like, golly.
Well, it was 30. It was like 30 degrees out, and she just doesn't wear shoes, or particularly little kids will be like, "That's not cold. I'm wearing a pair of shorts." So she's wearing a pair of shorts, no shoes on. She wanted to go to this little.
Is it too much of a hassle? Is it a statement?
I don't know.
Is it just like I don't?
It drives every woman crazy.
Oh yeah, because what do women love? They love shoes.
No, I mean, like a control thing. Oh, honey, you gotta have shoes. Well, you can't have shoes in here. Women workers.
Oh, like Karens.
Oh, it's awful, man.
It brings out everybody's inner Karen.
Everybody. I've stopped. I'm like, leave. I'm like, you tell her. I'm done. Go talk to her if it's that big a deal for you. And Nyla doesn't care anymore.
I love that. I do that with my kids too. If there's something they're doing that are kooky, I'm like, I don't worry about it. My wife gets. I'm like, oh, they'll figure it out, or they'll cut their feet, or I'm not going to get upset about it. Why am I going? I mean, what?
So
if you want to do it, go ahead, and knock yourself out. I mean,
we're in this little diner, and she decided to get a bowl of soup. So we're in a diner eating soup, no shoes on, underdressed.
Soup of all things.
It's like 10 o'clock in the morning. Right. We have chicken
Please,
soup.
sir.
This lady comes up to us and she's like, oh my gosh, what size is your daughter? She had a daughter with her, and I was like, huh? I was like, oh no, she asked how old she was, and I was like, oh, she's 5. Like, how old's your daughter? And she's like, oh, okay.
Elizabeth here has 10 pairs of shoes. You can have one of hers.
She went out in her car and got a jacket, a pair of pants and stuff. This is all we have, but I think it'll fit her. And then Nyla had no idea what was going on, so she's like, "Oh, that's awesome!" I was like a Christmas outfit.
She's like to score. Wow,
I was like, dang.
Nice.
So yeah, I've been there, but I don't know how we got from fertility to that talk, but nonetheless.
So are you trying to say that homeless people are infertile? What's going on?
I don't know. I was talking
they
about
don't live an optimal life for.
It's probably the environmental factors.
Environmental factors, exactly.
Fertility.
So
we do a lot of guys at our clinic. We'll just make a hard segue, no smooth transition there. We'll I do treat a lot of guys. I don't have a lot. I have a significant amount of people, and I'm daily managing Clomid, HCG, fertility, all those FSH monitoring, all that kind of stuff.
There's overlap too, right? So it's interesting, and I swear, man. It's a fun job in a lot of senses too, and it's funny. I like to laugh at myself. I like to laugh at the circumstances of my job sometimes, or this part of my job, or one of my jobs. It's really interesting having the discussions that you have routinely in such a clinic. There's a lot of talks about sex. There's a lot of talks about anatomy, right? So what I mean by that is, if we're talking about fertility, some of the medications, like for instance. Are you immediately desirous of fertility? And there may be a discussion of testosterone versus no testosterone. There's testosterone plus an ancillary drug, maybe an ancillary drug alone. Well, I don't necessarily want fertility, but I want to maintain testicular volume. Well, I don't necessarily want it. I'm not desirous of fertility, but I don't want to lose the volume of my ejaculate.
Now that you say that, all my guys are on HCG for volume. Oh, that's interesting. I wonder if that is a line. Yeah. I would say it's more dominant.
I had specific pointed conversations with these particular patients of mine. Okay, that's your body and what you're doing. That's fine. Here's how we can do it. So they overlap, right? And you may not need as much to maintain volume as you need per se for fertility. But let's say you have somebody coming in, and I guess here's the interesting thing too. You have to kind of classify what kind of patient it is. But let's give you an example and then see how you approach it. This patient has been on TRT in your clinic for 2 years. And patient's 29-year-old male who, since that time, got engaged, got married, and now is immediately desirous of fertility, or at least within the next year. His brand new wife, and he are going, or he are going to try to have it conceive. What do you say, and how do you approach it?
Yeah, so I think first thing I do is I tell people there's not a lot of guidelines out there. The guidelines that I were taught and learned is that if you have greater than 6 months, you stop TRT, and that is not a great option. I think if you have less than 6 months, you want to go ahead and stop TRT.
Less than
6 months, you go ahead and stop TRT. If you're 6 to 12 months, you continue and you add an ancillary. If you have greater than 12 months, you can continue TRT, and you may do some cycles of the ancillaries. I don't follow that strictly. For that gentleman, what I would do specifically, and what I do for my injectable patients, is I drop their dose by half of their testosterone, and I add in Clomid, and I want to see TRT levels maintain with half the dose. That's the first step I do if we have enough time.
So, wait, I'm sorry. Okay, I want to talk about the specific steps there, but real quick, you just said something at the very end. If we have enough time, by have enough time, what do you mean by that?
Meaning like you've given me an on-ramp, meaning not like, hey, we've been trying for 2 months and we can't get pregnant and I didn't say anything to you. But if you're like, hey, we're going to start, let's see, we're in July now. If you're like, hey, in 2025, I always tell people, tell me before you stop protecting. Like that's usually I kind of classify that as my first step. You know, most people get to this point of like, yeah, we're not necessarily trying, not scheduling, we're not doing that, but we stop preventing. If it happens, we're ready. If it doesn't, we're going to let it float for another long. That's when I want to know.
There's a clinical pearl too, right? So if you got a guy that started on TRT and is of an age or station in life, and you have to elicit this in conversation because they may or may not think about it, it's probably important to talk to them about future plans. Not probably. It is important to talk to them about future plans, and then tailor your therapy around that, but also tailor the next conversations around that. And there's planning that goes on. And like you just said, hey, if you want to be fertile in a year's time or however long, make sure you let me know 3 to 6 months prior so that we can begin that process.
I ask for 6.
And you never want to get in it. What's that?
I ask for 6 months.
Okay, yeah, it's even better. And then so that we can begin that process, we can front run that process rather than, oh my goodness. Now, there's not typically a physiologic or anatomic or structure or some kind of true medical reason that you want to have a child in a certain time frame, although that does arise. And interestingly, we saw that in our telehealth ventures recently with the patient, right? Yeah.
Forgot about that.
Wife has POTS, postural orthostatic type of syndrome, and followed by a cardiologist who deemed it unsafe to incur a pregnancy if it was not done within the next 2 years would be prohibitively unsafe, and so that did put a clock on the timeline. So that's interesting. It's rare, but that you would come across such a thing, but it's not like it doesn't happen. Yeah. So you start out with the ancillary drug of your choice. In this particular case, is Clomid.
Currently, well, as of 2024, it's Clomid because the current climate around HCG has become really expensive and hard to get, and so I have started using Clomid. So I start with Clomid, 25 milligrams, 3 days a week, or every other day.
So do you choose that? Do you choose that with a mindset that's similar to the mindset of start low and go slow? Meaning, are you trying to find one that's been found to be efficacious? Okay, so we know that it's been proven, at least in small studies, right? There is data, and for those patients, it's the cheapest one, most widely available of the ones you could select. At least has the least side effects of the two cheapest ones. Let's say, let's call those tamoxifen citrate and clomiphene citrate.
Right.
Knowing that you could ramp up later, is that kind of what your thought is, or
Yes, I use that as
and
like,
it's difficult
yes.
to get HCG?
I use it as like a dry run. I said, this is our testing. What I want to do is I want to give you fertility and not make you suffer. It's a balance between how much testosterone you're going to have to lower and how much Clomid HCG you're going to have to add. So this is how we start to get that ball rolling. I want to see how responsive you are. We've got time. You gave me the 6 months. Let's get this. And so, yeah, it's like I tell them we may, and I tell them before and during, we may have to come off testosterone completely, and we may have to go to HCG. That's my absolute preferred, and it is, however, the most expensive. And so, but that may be a reality for you. Or you may just say, like, I don't want to fiddle with this on-ramp. I'm going to just be done with this. Let's just go straight to it, and we'll get her pregnant in 2 months, and we'll be done, or something like that. But if that's not the issue, then I start, yes, as like a slow on-ramp. Let's get the ball rolling. Let's start that signal to your gonads. Let's get some of that repair started. We've got time on our side, and that's how I view that.
I view it similarly, but I like to make it completely patient driven, meaning I talk through different scenarios that are available and what they prefer given their budgetary constraints and their mindset and their demeanor and that kind of thing, or their take on things. Meaning, I guess in a to prime the pump per se, one might think that the absence of exogenous testosterone and then the use of ancillary drugs concomitantly would be the most stimulatory to gonadotropin production. So there was less negative feedback and then maximal positive feedback, let's say. You could make a scientific or clinical case that is the way it goes, right? And so, or you could even you could see where there'd be a concerned female partner. And I have seen this in clinic where, oh my gosh, how could you be on testosterone
Always.
and these drugs and assume that you're going to be able to get pregnant, right? So the argument against that, though, is, well, is what happens to somebody when they come off testosterone. They're incredibly suppressed. Especially, I use 3 months. If you can use 6 months, that's a good one too. And I just use that based on the small amount of literature there is. And so, if they've been on it longer than 3 months, I worry that the coming off is going to be difficult on them mentally and physiologically. Much like the guy that you described. Now he was a little bit of a different case, but similar at least. Who in another podcast you had talked about the guy on androgenic anabolic steroids. Mm-hmm. And so I say well, you got to have sex, you got to have intercourse to consummate the relationship and have a pregnancy in the first place. So if there's no testosterone, and we're doing that in the name of making the person's environment internally be that which would lend itself most to fertility. Now, the other drugs may work, but how quickly will they work has always been a kind of mystery to me, and I see a little bit in the literature about it, but everybody's different, and the volume of literature is small and poorly constructed studies if you want to, for predicting, let's say, prognosticating. So I worry that people would do so poorly and they won't feel like having sex, or they'll have low energy or low mood, or...
In which of those scenarios? In coming off testosterone completely, you're saying, or just even lower?
Sorry, yeah, I didn't. So just cold turkey, right?
Oh,
and
gosh.
even if you add ancillary, so I worry about that. So I like your method, and I mirror your method where you drop it by half.
You mean because sort of a standard protocol of just not standard, but like maybe I don't know what I even call it because it's not standard, but the protocols that we say just you should come off testosterone completely. That idea you're saying.
Right.
You don't like.
So I like the idea,
and I don't think it's necessary. I don't.
It's not. It's not necessary, and furthermore, it seems to be fraught with failure because the person's going to feel like crap.
Yes.
And there's going to be a lag time. So,
I think it's a well thought out or poorly thought out plan. I think it lends itself to an era gone by where we didn't understand testosterone. It was viewed as this anabolic. It was viewed as this thing that people were abusing and doing all this stuff. So you should come off it, dude. You just got to come off it. Because that's what I hear fertility clinics and PCPs in my area still telling men. I'm like, well, you have a sperm test. Like we did a. What do you, I don't understand why you would have to come off it. We have the actual data, so I think that's a poorly constructed pass down.
I agree,
argument.
and it is poorly constructed, and it's. I don't mean to say this in a negative way. It's going to sound that way, but it's usually the result of a person that's naive to treatment of these individuals, meaning they haven't treated enough people to understand what it's like
100%.
to come off of that, either themselves or having patients. And I remember distinctly, Jeff, see if you recall this. When we were getting your clinic up and running, I was teaching you this, and you had become a patient yourself, and it was the beginning of our kind of efforts together and teaming up, where we had a patient come in who was late to getting his pellets, or there was some, I forget exactly why.
I do remember. I know exactly what you're going to say.
Yeah, came in bawling and just upset and frustrated, angry, and just, I mean, it was bad. It was like almost a kind of a psychological break point, and I think it shocked you a little bit. Or it was you or somebody. There was somebody and I said, yeah, this really can happen. Or maybe the patient himself, or both, or everybody. And I said, no, yeah, this definitely can happen. This is absolutely likely from testosterone, and got his testosterone and was instantly better. Can you imagine being under those mental conditions and physiologic conditions, and then trying to conceive
Then trying to have a baby?
Yeah, when we know that even normally fertile couples, there's only let's say a 33% or 25% chance each cycle, which means you have to have sex like it's your job and having it, we just discussed in previous episodes. I mean, that is just, come on. I mean, that's just crazy.
Yeah, I don't think it's necessary.
It's not necessary. So
I think also, here's one thing I would like to point out. I think a lot of times these protocols and the way that some physicians practice come out of lack of time and lack of, I don't think it's lack of care. I don't find that to be true. I think it's just lack of time in the system. It's like to sit down and have a long conversation with somebody, to think about this, to plan about that. That might be a 45-minute conversation, realistically. What standard primary care clinic, a doctor has 45 minutes? There's no way his insurance and his HR department and all that are giving him 45 minutes to deal with that. So, it's damn near impossible. So a lot of times these protocols are just written out of that paradigm, is like, just tell them to come off it. If they need to, go on HCG. Right? That's just a quick, easy, not like, oh, the protocol is talk to the patient, find out what's best for them, spend 20 minutes with them, talk about the pros and cons, talk about the risk reward, talk about their history again, and then start a conservative plan and meet back in a month and see how it's going. That's,
also, it comes from a naivety, not in a, I don't mean to say it in a condescending way, but just the mere fact of experience. Like,
correct.
I guarantee you, if you talk to a PCP, hey, your framework and your skill even at treating hypertensive patients, dyslipidemic patients, diabetics, would you compare that to yourself 5 years ago? You're probably much more mature, dialed in, have a handle on it, right? So if you're only seeing one or two of these patients as a PCP every now and again,
that job's tough. You got to be good
at all those things. Not only do you not have enough time. Yeah. I mean, can you imagine? And then trying to do that without the experience and some kind of clinical background on top of the knowledge base of learning the subtleties of it, it's just difficult. And it's difficult to carry it out in an efficient fashion. I agree. So what I'll do is I'll kind of try to tailor it to the patient where they're coming from. I'll say, here's the preferred method. My preferred is HCG. And then I even have preferred dosages based on the little bit of literature there is. Like, we know that after a year of injectable testosterone, or even a couple of years at TRT doses, you can get a 70 to 75% restoration rate after 6 to 12 months on HCG at a dose of 1,500 3 times a week, similar to what a drug monograph would recommend if you look at the Pregnil drug monograph. There is data that there was one study I saw that 5,000 units 3 times a week had an even higher rate of
5,000 units.
Yeah, 3 times a week. Now it can be up to, in the range goes up from 1 to 10,000 units 3 times a week. If you look at the drug monograph,
the cost on that though is.
But there you go, and that's why you have to tailor.
Prohibitive.
Exactly. So this particular study, Let's see how many patients
And
were
that
there.
study was done before the price went nuts, right? The FDA specifically reclassified HCG, as I understand it, as a biologic, which disallowed
That's interesting.
compound pharmacies to make it. And now the price went from, I think we used to get it for patients in the $60 to $70 per 10,000 units. Now
Well, it could be compounded, right? Yeah.
Yeah, it could be compounded for that. Now it's Pregno, and my cost clinic is $275 per 10,000.
Yeah.
So if you're doing
this
5,000 3 times a week, you're looking at, $400 a week.
Yeah, that's correct. Yes, this is an older study at that time. Yes, that's correct.
But I don't think that would have played into the study's not necessarily going to play into that though in their protocols.
Meaning they're not concerned necessarily about cost and so forth.
I don't think they would. I mean, maybe they do, but I don't think they would have. I tell people it is still the gold standard as far as I'm concerned. HCG.
Oh, correct.
Cost or not cost.
Right. So I talked about cost. I talk about what your time frame is, what you desire, how do you desire to approach it. So I tend to let the patient lead me a little bit based on the literature, my clinical, my empiric evidence in my clinic. Interestingly, I've been this patient myself 3 times for 3 successful pregnancies. So it's a bias in a sense, but it also gives me a clinical a way to understand it, and a way to say I've been there and this is kind of my experience too. So it's kind of a double-edged sword. And that's exactly what I did. I ran a little bit higher.
Of them, huh? The last 3 have been
all 3. Yeah. Well, yeah, 3 of the 4. That's correct. The last 3 were. And so interestingly, what if someone said, should I take an FSH analog or should I take HMG, or do I have to worry about my FSH? What does HCG do? How would you explain that to them?
I didn't hear your question. Sorry, I was reading. I was looking at this study. If I'm honest, I didn't hear that question. But I thought this was interesting. It was TRT, intratesticular testosterone, was reduced by 94%. In men receiving TRT plus HCG at only 250 units every other day, intratesticular testosterone was reduced by only 7%. And so I think that is, it is effective and it's quite possible to do. Tell me what your question was again. Sorry, I wasn't paying attention.
Well, so just like testosterone would reduce just like testosterone will induce gonadotropin suppression in a dose-dependent manner, so does HCG tend to stimulate intratesticular testosterone levels in a dose-dependent manner. Meaning, and it is kind of obvious, but just to clarify a little bit, 125 IUs, for instance, a day or every other day, will raise intratesticular testosterone less than, say, 250. I mean, obviously. So it's not as though it's not a one dose exerts the same effect as So it helps me understand that there is a role for higher dosing, and it also helps me understand why, if you've got time, your system and framework is a nice way to do it too, because it's looking for to me, whether you mean to or not, and I think you do, and that's good, because we learn. Not only are we brothers, but you can't hang around with somebody long enough, or as long as we have not kind of understand their take on how they approach things. But it gives you the lowest effective dose, basically, and I think that is important in the current climate of difficulty obtaining HCG and the expense of HCG now, because I compare it to when I did it, and I got it from a compounding pharmacy, and I was on a doctor's salary. And what's that?
How many units were you taking?
Interesting. It ranged 5,000 3 times a week. The first 2, 10,000 3 times a week on the last one.
Damn.
Yeah.
A week? I mean, an injection?
3 times. Yeah, per injection 3 times. Yeah.
Oof. I mean, that's like
blowing through some HCG.
So HCG, man. You'd be doing.
Talk about blue balls.
$275 per shot 3 times a week at today's pricing. I don't know. It's crazy. I don't even know how this. Not only is it expensive, that's one thing, but it's difficult to find. You can't really readily get it at a CVS, Walgreens, Publix here, and you can't.
Plus, for somebody that's getting, assuming they stay on IM injections, you know how many injections a week that is? Whew.
Loading them up.
I mean, it's like a pincushion. It's rough.
Yeah.
But when your wife wants a baby,
You do what you got to do.
you do what you got to do.
Now, was yours a matter of you just let's get this over with and let's just get it done, or were you like you had gotten to the point where lower doses didn't seem to be effective in your estimation? Like, why did you go that high?
On the so the first one was urology directed and probably based, although I don't know if I can't remember having specific discussions, but based on the I remember this. I started at lower doses and then I couldn't. Okay, so I started at lower doses of HCG.
Mm-hmm.
I do remember testicular volume picking up a little bit. I do remember ejaculate volume picking up. What I then remember was not feeling. It became what I sensed was whatever testosterone level I was sitting at, I was doing no testosterone with it, and I ended up being at a serum testosterone level just under 500, and feeling like crap and dragging and having a high performance job, i.e., trauma surgery that I had to be present. I had to be on point all the time, And so I couldn't function like that, and I went back to the urologist like, man, I can't. So then that's when we started the concomitant intramuscular testosterone cypionate. And at that point went to a higher dose because there was going to be more endogenous suppression, I guess was the thought. I will say we had not waited long enough, but on the first child, it had gone on, and 6-7 months trying really hard and not having a result. So I think there was pressure I felt to speed up the process. By the time I got around to the third kid and treating patients, I thought, and this is, it was probably more of that speeding up the process.
Yeah.
Plus, you probably a little bit of voodoo science too about how you can kind of feel or tell, or that's not the way it should be with a patient though. You should be checking, like the patient you described, checking your.
We don't ever do that with ourselves, though.
Sperm testing, huh?
You don't ever do that with ourselves, though.
No, doctors are the worst patients. They're the worst. They're the worst.
And also, I think one thing is to consider is you're willing. You were willing to do the injections at a large volume. You were willing to pay the money for them. You were willing to do
I had the resources.
You had the resources.
Yeah.
And a lot of patients are like, what? I got to add, that's a big volume injection. I got to add that 3 times a week. They just might not be willing to do that anyway.
That's a good point, too. And so that was interesting, too. We played around with my wife, who is now a nurse practitioner, but at the time a nurse.
Did you super concentrate it?
Exactly. Intelligently said, hey, why don't we just try to get away with... I said, blah, blah, blah. And then she was smarter than me.
10 ml injection.
She actually came up. I'm like, oh my gosh, you're smarter than me. I knew you were smarter than me at life skills and life, whatever. Now you're smarter than me in medicine. Jeez, it's humbling. But yeah. And then so we super concentrated and it worked. So it was a lower volume.
Yeah.
I like HCG. I like your frame.
Yeah, I was gonna say my next step is we drop that and we drop the testosterone dose in half, add the Clomid or enclomiphene, and then the next step I do, step 2, is we add HCG. I'll do 500 units or 1,000 units.
Add it and keep the clomiphene.
And keep the clomiphene. I'm coming out of most of my patients, and maybe it's just coming from I'm transferring this to my patients, but most patients it's become difficult to keep the HCG in stock and keep it. There was this like starting stopping when we were doing big doses, and it's expensive, and so I like to team them together. So I go to 25 milligrams of enclomiphene every other day, and I add 500 units of HCG 2 times a week. So now we're adding those both. That's my next step, and that gives you like we have to balance price and efficacy and all that kind of stuff. And I just keep telling them we may have to come off this and add HCG altogether solely.
Mm-hmm. Yeah, I tend to go a little higher dosage on the HCG as long as the patient has the resources to do such. I tell myself that's a literature-based thing, although the literature is shaky. I also recognize that my personal bias of having been a patient plays into that. But there is physiologic proof or proof of physiology there, right? Or proof of concept, meaning that the intratesticular testosterone raises on a dose-dependent manner with the HCG. But
I mean, I called you on my last on it. You probably don't remember, but I was like, man, I'm stuck on this guy. And you said, well, what do you got him on HCG? And you're like, you're not doing enough. And I was like, it's so damn expensive, man. He's balking at it. And he's like, and you said to me, how bad does he want a baby? And
Exactly.
And so I said that to him, and he goes, you're right. So we did it, and he got HCG solely. I think we went to 3,000 units per dose, and got him a baby.
Yeah, nice job.
So,
and it gets you know, it is scary because there's not a lot of literature. There's not a lot of people you can talk to about it because it's such this niche thing. And I don't know if you're a fertility specialist. I don't know how much you're doing that, or if that's more do they feel like that's more relegated to practitioners such as us, and they're more the IVF and
I think so.
What is it,
That's
IUI, and and so and so we're kind of left trying to piece this together with a lot of deductive reasoning. Now, we use physiologic concepts and principles that are sound, but again, the literature is sparse. And so, I do have a bias, but it's nice to kind of have been a patient, honestly. It has
that helps a lot.
It helps
in
a
all
lot.
This.
Yeah, I think that really informs me. I feel like it does, and at least to help them understand what it's like. And the whole thing about how bad you want to have a baby, that was the thing with me. I was like, what? I have to pay how much? And then... or how much staring from my wife or discontent on my wife's behalf can I stand before I relent? But I wanted to have a baby too. It wasn't like but I mean, you're right. And so the ironic thing about that is the cost is nothing compared to what the child is fixing to cost you once they come out of the womb.
True.
And you're
it's
like,
already just
oh
started.
my gosh.
Just stop mentioning this. Is just
you
the way
thought
it's
that
going
was
to be.
expensive. Wait till you raise a kid.
That's a good point.
God, yeah.
That's a good point.
Jeez.
Yeah, that's the cheapest part is the conception.
Now, I will say something else too. I have not seen. I think there is a little bit of literature. It was either not compelling enough, or maybe it's just an overload preparing for this podcast. I don't seem to recall it. What I can seem to recall is that it was not of any efficacy greater above and beyond monotherapy alone to really warrant, to stick in my head at least, but the combination of HCG and Clomid. However, that being said, it's a really nice thing to think about, and it makes physiologic sense in the following. HCG, human chorionic gonadotropin from the chorion, i.e. placenta, etc., is a hormone that is an analog to luteinizing hormone. It stimulates the Leydig cells to then render elevated levels of intratesticular testosterone, and even though FSH is suppressed, still promotes to a powerful degree fertility. Okay, works at the level of the testicle, whereas clomiphene and tamoxifen are SERMs, selective estrogen receptor modulators, and it blocks a signal through competitive inhibition. Competes for the receptor site at the level of the hypothalamus and pituitary gland to trick the body into thinking there's less circulating estrogen around. Thus, it says, oh, okay, I better produce more LH, FSH. So I like the combination because you're treating it at the level of the brain. So you're treating the entire axis, hypothalamic pituitary gonadal axis, as opposed to just one. However, that being said, what seems to be most important is neither the LH or the FSH, although indirectly, clearly they're important, but it's the intratesticular testosterone. So it makes sense. There's physiologic, through deductive reason, you can kind of reason that out and say, okay, it makes sense to do that. How much more efficacious they are than monotherapy alone, it's difficult for me to parse out. How about you? What do you think about that?
I agree. I think one of the reasons I like having Clomid as a start as well is while FSH and LH levels are not indicative, demonstrably of intratesticular testosterone, it gives a clear value of a suppressed LH, FSH. We add something that FSH, LH returns to normal. It's a trackable thing. And so that is a good, clear, objective measure that I can use. It is often confusing to guys when we switch to HCG. They're like, hey, my numbers are now suppressed. Why I'm not doing enough. I'm not getting enough. I'm like,
Yeah, exactly.
You're not,
right.
yeah, you're not understanding, and not to their fault
Right.
by anything, but yes, I did a poor job, I should say, of explaining how the Clomid would work versus how the HCG. You won't get that rise from the HCG on those FSH, LH numbers like you would on the Clomid. So the Clomid gives them a trackable, objective measure, while not, 100% indicative of intratistic. Their testosterone is part and parcel of that value.
Interestingly, the data that I saw too showed that while Clomid and tamoxifen can both do reliably increase the amount of sperm per milliliter ejaculate, they don't seem to affect the motility and the morphology
Oh, interesting.
to the positive, or I guess, or to the negative either. And I don't. And again,
Whereas HCG did at a better rate.
Well, I don't recall. I think that it did. I honestly don't recall, but they don't seem to do that. So it's interesting, and that's so it's interesting. Okay, so what do you do about it? Well, clearly you want a lot of sperm. Not only do you want a lot of sperm, but you want sperm that are healthy, motile, with optimal morphology. Not wonky looking sperm, basically, right? And not ones that are just kind of going around hitting the corner, just like boom, boom. You want your boys to be after it, right?
Swimmers
going for the gold.
Yeah.
So how do you do that if not through hormonal therapy? I don't think HCG did either, and that's to me where the conversation isn't complete until you discuss diet and exercise. That has been proven to impact sperm quality and possibly quantity. That's where you talk about ancillary treatment with ubiquinol, i.e. CoQ10, which there is actually compelling data for that.
I remember you telling me about
I
this.
was
Educate
first,
me a little. I got to be
well,
honest.
exactly.
I don't know a whole lot.
Yeah, I don't consider myself an expert in it, but here's what you need to know and how you can kind of cut to the chase with that. Everything in medicine is a risk benefit, right? What is the risk of taking normal physiologic or accepted doses or safe doses of CoQ10? As best I can tell, almost no risk, right?
Cost, time, effort, money.
Right, that's true. Time, effort, money. Okay, for sure. But it's not super expensive.
No, yeah, I'm saying, in other words, that to me is like nothing. Yeah.
Right, and with Amazon, you can just be there the next day, right? So, very little. So any benefit I can accrue in a game of incremental benefit acquisition, which is important here, right? Especially when I'm going to come at it from a totally different perspective. Great, you gave me a bunch of sperm, but did you give me a bunch of duds? No, I want some studs, right? I want
boys.
duds. Studs, not duds.
Michael Phelps.
Studs, not duds. Yeah. So I'm going to use that in the clip. So oxidative stress.
Mm-hmm. It's a big one.
And internal cytokine milieu definitely impacts the quality of your sperm. If you are an obese, overweight, sedentary smoker, your sperm, not only will the number be low, not only will your testosterone probably be lower, and your intratesticular testosterone, but you're going to have duds, not studs. So we're going to get our diet on point. We're going to get our exercise regimen reinstituted. And we're going to use the compelling data of CoQ10. There is evidence, although it is less compelling, of carnitine too. So, and I remember learning this from my urologist way back when I hadn't went there. So what did I do? I went right down to the health store. Now you want a vetted supply chain. You want a vetted brand, I guess, if you will.
You have
to know what you're getting.
The supplement market is a shit show.
Shady.
God.
No FDA regulation.
Yeah.
So assuming you can do that and get good CoQ10, again, that's
doesn't
where
help, but that's a different story.
What's that?
I said the FDA oversight doesn't help. It just gives you bigger dollars.
Yeah,
It just gives you cover to cheat.
Well, yeah, the last few years
I've lost all filter. That's they're garbage.
It's horrible. But so you want to get their CoQ10 levels up. You want to get your, I don't know, throw some vitamin C in there. Why not? Some glutathione. Why not? I mean, but the ones that I know of that have been data proven are specifically ubiquinol, i.e. CoQ10 and carnitine. So I like to have my patients, again, talk. By the way, your endothelial responsivity, i.e. erections, and your vascular health, your mood will be elevated. You got to be in a certain fitness level to tolerate that much sex. I mean, it's like it all.
Are you in shape, buddy?
Come on. You're gonna have to do. I mean, this is like not your just obligatory once or twice per week.
Sounds like a gym meme there. Some those video recordings of people at like Planet Fitness or whatever doing ridiculous stuff.
Globo Gym, exactly. So that's not the end of the story. So to make sure that we have the highest quality sperm, we want to make sure the internal milieu of the body is at its physiologic best, right? Diet, exercise, and judicious supplementation with, for in this case specifically CoQ10 and carnitine and other antioxidants are important. They're not the end all be all, but they're important. So that's how I look at it. So I make sure it's just one piece of the puzzle, for instance.
I think a good thing to point out maybe for listeners is have this discussion with your TRT provider prior to starting TRT to make sure they even have a protocol in place, or are they just going to say, come off of it?
Good point.
I've talked to a lot of practitioners, and a lot of this market, because I'm involved in the training side of it, I'm not the one making the decision, but the focus a lot of time is on how to deliver the hormone properly, what's the best dosing, what's the best route, here's how you do your pellets well, here's how you do injectables. But rarely am I teaching people on the fertility protocols. And so I think a lot of focus has been on the delivery. A lot of focus has been on the benefits on that side of things, but not a lot has been talked about on the recovery, on the coming off, on the post-cycle therapy. You're going to have, if you step into this world, whether you like it or not, whether you agree with it morally or not, is irrelevant. You're going to have guys coming into you who have done post-cycle therapy from anabolic steroids improperly and are going to want that information and need that information from you in order to recover from that situation. And I think if you're going to open the clinic, you got to know that side of the equation.
Yeah, exactly. And it gets down to the root cause of why is there so much bro science, in fact. Well, okay, now clearly there are people that want to abuse them and which is a whole other thing too. It's like, that's another misunderstanding is, do you really even need that stuff to get the look you're wanting anyway? Probably not. The longer I'm in this field, I almost feel like, what's the point? I mean, like above and beyond of,
I think I tell people it's the 1%ers. You know what I mean? Like it takes... to be a pro at IVFF, whatever, you're talking about a mental shift that you don't even have the capacity to do. So why are you fiddling around with trend? You're a plumber, and you want to stop. You want to put on 10 pounds of muscle. That's the dumb. You know what I mean? Like it's not how it works. Those are niche things that niche people abuse that are,
but ultra niche. Like
that's what I'm saying. Really niche.
The stuff that you could do with optimized safe levels, good nutrition, getting hold of our colleague Dr. Sokolowski's app or whatever app you like, his app Physique, which is phenomenal, and in his wealth of information and just how to perform the exercise correctly and it's unreal what you can do. I remember a comedian. I once saw a comedian. He was like talking about working out and why he wanted to start working out, why he did. And he said, I don't want to be a lumberjack. I just want to look like I could be, or something like he just want a certain physique or whatever. And so these people want. I mean, unless you're in the 0.5% or even 0.1% that want to be Arnold or Jay Cutler.
You ain't got it anyway. You're not that guy. You don't have the dedication. You don't have the mindset. Right. You know what I mean?
It's not just steroids anyway. Exactly.
You don't.
And you don't have the budget for that. You don't have the like.
Those guys are so regimented, and man, is
so don't even do it. Because you can achieve your aesthetic goals with just very simple, safe methods. Anyway, I think you're right. So number one, on the patient side, make sure your practitioner has those protocols in place. A lot of people don't even realize it. Got low T? I'll just give T. I mean, I get it. That kind of makes sense on the surface level, but once you understand in the body what's really going on, there's so much going on, right? That is that is the tip of the iceberg, my friend. Yep. Then on the practitioner side, don't open this and not know, because why did most of the stuff like bro science start in the first place? Yeah, some of it is wanting to do stuff that's way off anybody's radar and protocols anyway, but a lot of it is because the practitioners don't know it and aren't taught it, and there's no protocols like this. So provide that information and let's help fill a gap that exists.
Yeah, I have a little problem too with some of the bro science being looked upon poorly. I think a lot of practitioners still, that's changing, but they're like, oh, they don't need testosterone. Oh, you don't need, your levels are 400. Oh, your levels are 300. You're normal. And I'm like, so my counter to that, to primary care, when they say that, is like, how many Adderall scripts have you written this year? And how many of those patients were Adderall deficient? Just curious. I mean, I'm not saying, because I'm not going to judge you.
Let's just call it what it is, amphetamine deficient.
Yeah.
Right?
So how many of your patients, and you, sir, because I think it's quite well known that a performance-enhancing drug that improves your concentration could be used to get through a rigorous academic program. You may have dabbled in some Adderall usage when you were going through med school or taking high-performance testing. Were you also Adderall deficient, sir? So don't – I get a little – touchy, as you can tell, because I think the bro science came out of need, man. Like it's okay. Yeah, I'm saying you, but like when I get crap from primary cares from an uneducated standpoint, not to bastardize them, but or internists or whoever it would be, another physician, because I'm practicing testosterone replacement on someone who has testosterone of 350, and that's considered normal. I think it's a poorly understood position, and it doesn't hold steady across their prescribing norms in other areas as well. So I think there needs to be a shift on that.
No, 100% there does. Interestingly, because there's a lot of subtle nuances. I saw a guy recently who was a clinic, so it's easy for me to take the moral high ground here. I recognize it. I'm going to say it up front because I was not the guy that put him on testosterone initially. And by the time he got to me, he had been on it for 3 years. So no matter what, it was done. I mean, his HPG excess was suppressed, he needed it now no matter what. But it shocked me a little bit. And I said, okay, well, what was your original testosterone back when you were diagnosed with hypogonadism or functional hypogonadism or what have you? He had symptomatology. Or he had symptomatology that was consistent with hypogonadism, and then what are the lab values that correlate with that? And he said, "Oh yeah, I was like 600 or 700." I was like, "Whoa, wait." I was like, "What?" That even shocked me, right? I said, "You're pretty good total testosterone." He said, "Yeah, but here's the interesting thing: the guy had a seizure disorder. He had been treated with valproic acid for 25 years, maybe 30 years. He came to me as a 48-year-old man, and the effects on the liver with anti-seizure medicines and valproic acid are well known, and the induction of SHBG in this guy was massively high. So somewhere along the way, he said, "Look, and this is again, you don't. So what you're talking about when you're talking about the judging, the paternalism, is really not listening to the patients, because why are they seeking this out? Now, if you're hell-bent on destroying yourself or some kind of insecurity, okay, and by the way, why don't you listen to that and help them with those things too, body dysmorphia, because those things are real. But if you judge too quickly or judge at all sometimes, or if you are too paternalistic, you'll miss what your patients are saying to you and you miss a chance to help them, right? And just because you're judging. But interestingly, a PCP, and the guy commended his PCP, whoever it was at that time, to check a little further, because the guy kept just saying, "Look, I know I'm having erectile dysfunction, I'm having this, I'm having that." And they got a SHBG and a free testosterone. His free testosterone was in the toilet because his SHBG was incredibly high from the valproic acid, or assumed to be from the valproic acid. And I was like, makes sense. I've seen it especially in women with estrogens, induction of SHBG, inducing the liver to produce more SHBG. So, I have to
tuck that one away randomly. I've never heard that.
Yeah, it was new for me too.
I'll put that in
so
my brain
your point's
somewhere.
well taken on that. Interesting, right? So, those is how I would probably choose. I think both frameworks. Now, is there a role for tamoxifen? For me, no. Does it work to improve sperm counts and even testosterone after being on suppressive doses of TRT? Yes, but as I saw one article point out, the risk outweigh the benefit insofar as, it's a SERM, but is so much like estrogen and synthetic estrogen that it is known to be associated with venous thromboembolism disease, just all the negative things about estrogen or synthetic estrogen that exist out there, and considered too harsh to be used in this realm for that purpose, especially when there's ones that are well tolerated like clomiphene, and then non-SERMs like HCG. So I don't find that it has a clinical utility at all, and nor does aromatase inhibitors, except for maybe in trying to quell estrogen that's a byproduct of raising your testosterone while on Clomid or something like that. But as a monotherapy,
I see more estrogen production from clomiphene and clomiphene than I do from HCG.
Oh yeah, and it itself is an estrogen analog, so it can give you some symptoms.
Yeah, I think you get less with the N-clomiphene, but it is still still present. But it works great in younger guys. I don't want to keep going down rabbit holes, but I find it to be quite effective on the 20-somethings, the N-clomiphene, clomiphene.
I have too. I've seen some data that was kind of old at this point out of the Mayo Clinic too, that kind of turned me onto that back in some years ago, 5 to 8 years ago. Pretty compelling, and I find that it's good too for guys that desire fertility concurrently or immediately as a substitute for one on TRT. What I have found, working for younger guys rather than older guys, it makes sense because at some point your testes should become less responsive to LH and FSH, similar to an ovary becoming less responsive over time. What I have found is there seems to be kind of a tachyphylaxis or some type of guys seem to be less responsive after about a couple of years of therapy. I only found it in my clinic, in my experience, it's only bought me a couple of years, and we're talking on, I don't know, maybe 15, 20 patients. So it's not like I have a massive number of patients I've treated on it, but that's just an observation I've seen. Well, maybe there's a role and a way to prevent infertility with at the same time you're using testosterone, and maybe a way to come off of it and have a recovery protocol. Maybe we should talk about that next time. What do you think? I know we're running out of time, and we're definitely running out of time, but
yeah, I definitely think there's a role for that, and I tell guys if there's a concern, let's just run them concurrently at the same time. That's definitely a protocol.
Well, would you mind coming back on and let me know a little bit more about how you approach that in the clinic?
I would, brother. Let's do it.
All right, man. America.
Peace. America. Peace out.
See you, man.